Hello everyone, welcome to Tawheed Foundation for Allied Healthcare Sciences, Bangalore. Today's class is about immunology. Topic is hypersensitivity for BSc MLT third year students. So before we proceed, today we are going to talk about hypersensitivity, which is essentially when the immune system overreacts to substances called antigens. Normally, our immune system protects us, but sometimes this response itself can cause tissue damage or disease. Hypersensitivity reactions are classified into four types called type 1, type 2, type 3, and type 4 based on the immune mechanism involved. Type 1, immediate allergic reactions mediated by immunoglobulin E antibodies like asthma or hay fever. Type 2, antibody mediated cytotoxic reactions where IgG or IgM attacks cells, for example, in blood transfusion reactions. Type 3, immune complex reactions where antigen and antibody complexes deposit in tissues causing inflammation like in lupus. And type 4, it is delayed type T cell mediated appearing after 1 or 2 days, seen in conditions like contact dermatitis or the tubulin skin test. We'll go through each type in detail, understand how they happen, and see some example. This will help you link the mechanism of immune response to actual diseases. So coming to introduction part, introduction to hypersensitivity. When our body encounters an antigen, the immune system is activated to protect us normally. This response is well controlled. The immune cells release effector molecules like antibodies, complement proteins, and cytokines to eliminate the antigen. This usually causes a mild localized inflammation that helps clear the threat without damaging our tissues. However, sometimes the immune system overreacts or reacts inappropriately instead of providing protection. This reaction itself causes tissue injury. When this happens, we call it hypersensitivity or allergy. So, in simple terms, hypersensitivity occurs when our own immune system, which is supposed to defend us, ends up harming our own body. Next is definition of hypersensitivity. Hypersensitivity can be defined as an exaggerated or inappropriate response, immune response that damages tissues instead of helping in recovery. These reactions play a major role in many diseases, ranging from mild allergy conditions to severe systemic disorders. It is important to note that hypersensitivity is not seen during the first encounter with an antigen. The immune system must first be sensitized. Only upon subsequent exposures does the immune system react strongly, leading to symptoms of hypersensitivity. The antigens that trigger these reactions can vary from one individual to another, which explain why some people develop allergies while others do not. Next is key concept overview. So here we can visualize how the immune system responds differently to the same antigen. When the immune system functions normally, exposure to antigen leads to protective response and the antigen is eliminated without harm. On the other hand, if the immune response is inappropriate or is exaggerated, the reaction can causes tissue damage. This is the essence of hypersensitivity. So while the antigen is the same, the outcome depends on how the immune system reacts to it. So these flowchart helps to differentiate a normal protective response from a harmful hypersensitive response. Next is gel and Coombs classification. To better understand hypersensitivity, Gel and Coombs proposed a classification system dividing hypersensitivity into four types: 1, 2, 3, and 4. Each type involves a different mechanisms, different immune cells, and different mediators. So, type 1 is the immediate allergic reaction like asthma or anaphylaxis and involves IgE antibodies. Type 2 is cytotoxic, where antibodies target specific cells causing cell destruction. An example is hemolytic anemia. Type 3 involves complexes formed by antigen antibody combinations which deposit in tissues and cause inflammation, like in serum sickness. Type 4 is different. It is T cell mediated and called delayed type hypersensitivity because it develops over 1 or 2 days, such as the tuberculin test or contact dermatitis. Next is, so understanding this classification is crucial because it helps us identify the mechanisms behind different hypersensitivity reactions. Next is broad classification based on timings. Hypersensitivity reactions can also be classified based on the timing of their occurrence. Immediate hypersensitivity involves antibodies produced by B cells, mostly IgE and sometimes IgG. These categories includes type 1, type 2, and type 3 reactions. Symptoms appear quickly, usually within minutes to a few hours after antigen exposure. Delayed hypersensitivity, on the other hand, involves T cell rather than antibodies. This is type 4 hypersensitivity, and the reaction develops more slowly, usually after 24 to 48 hours. Understanding this timing is important because it affects both the diagnosis and management of hypersensitivity disorders. Next is immediate versus delayed hypersensitivity comparison table. So this table summarizes the key differences between immediate and delayed hypersensitivity. Immediate reactions are antibody mediated, occurring within minutes to hours, and include conditions like allergies and serum sickness. They work through antigen antibody interaction. Immediate reactions, delayed reactions, are mediated by T cells and appears after 1 or 2 days. An example is the tuberculin skin test. In this case, the immune response itself, primarily T cells, leads to tissue inflammation. Recognizing these differences helps us predict the onset and type of symptoms in patients and choose the correct treatment approach. So, what we can see, this is a comparison table between immediate and delayed type of hypersensitivity. Its features include mediator, reaction time, example, and mechanisms. Mediator of immediate hypersensitivity, it is antibodies, and for delayed type, it is T cells. Reaction type for immediate hypersensitivity, it occurs within minutes to hours, whereas in delayed type, it takes around 1 or 2 days. Examples of immediate hypersensitivity include allergy, serum sickness, whereas in delayed hypersensitivity, example is tuberculin test. Mechanism of immediate hypersensitivity shows antigen antibody interaction, whereas for delayed type, it shows cell mediated immune response. Next, what is type 1 hypersensitivity? Type 1 hypersensitivity, also called immediate or anaphylactic reaction, occurs when the immune system reacts inappropriately to certain antigens called allergens. Normally, the immune system protects us by providing antibodies like IgG or IgM, but in this type, plasma cells produce IgE antibodies instead. These IgE antibodies have a special property. They bind strongly to mast cells and basophils through receptors on their surface. This process is called sensitization. When the person encounters the allergen again, the allergen binds and cross-links the IgE molecules on the sensitized cells, leading to degranulation. The mediators released during degranulation cause vasodilation, smooth muscle contraction, and the typical allergic symptoms like swelling, redness, and difficulty in breathing. So, this is type 1 hypersensitivity. It is induced by specific antigens called allergens. It is similar to normal humoral immune response. Key difference for type 1 hypersensitivity is plasma cells produce IgE antibodies rather than or instead of IgG or IgM antibodies. IgE binds strongly to mast cells and basophils via Fc receptors. On re-exposure, allergen cross-links bound IgE, which leads to degranulation, and then mediator will release. Next is mechanisms of type 1 hypersensitivity. To understand the sequence of events, let's follow the flow. So first, exposure to the allergen triggers activation of B cells. These B cells then differentiate into plasma cells that produce IgE antibodies. The IgE antibodies bind to mast cell and basophil. That process is known as sensitization, making them sensitized cells. Upon second exposure to the same allergen, the allergen cross-links the IgE on the surface of these cells. This cross-linking causes the cells to degranulate, releasing mediators like histamine. These mediators cause allergic symptoms such as bronchoconstriction, increased vascular permeability, and inflammation. These mechanisms explain why the first exposure sensitizes, but the reaction occurs only on subsequent exposures. Next is key components of type 1 reaction. There are four main components necessary for type 1 reaction. Those four components are allergens, IgE, that is reagenic antibody, mast cell and basophils, and Fc receptors. Allergens, these are the allergens that triggers the allergic responses. IgE antibodies, these are the reagenic antibodies that mediate the reaction. Mast cell and basophils, these are the effectors cells that contain granules with chemical mediators. Fc receptors, these receptors on mast cells and basophils bind the Fc portion of IgE, anchoring the antibody to the cell. All these components must interact in a coordinated way for the allergic response to occur. Without any one of these, the typical allergic reaction does not develop. So all these four components are essential for allergic response to occur. Next is allergens. Allergens are non-parasitic antigens capable of inducing IgE production. In some individuals, especially those with a genetic predisposition called atopy, allergens trigger an exaggerated immune response. Common allergens include plant pollens, drugs, foods, insect products, animal products, and mold spores. So, common allergens which include plant pollens like ragweed or ryegrass or timothy grass, drugs such as penicillins, sulfonamides, and salicylates, foods like nuts or seafoods, insect products like bee venom, bee or wasp venom, dust mites or cockroach parts, animal products such as dander or serum proteins, and mold spores. The degree of allergenicity is influenced by several factors: the dose of allergen, the route of exposure, the presence of adjuvants, and most importantly, the genetic constitution of the individual. Next is genetic basis of atopy. Atopy refers to a hereditary tendency to produce IgE antibodies against common environmental antigens. Individuals with atopy often have high IgE levels and eosinophils count. Two important genetic loci are involved: chromosome 5 locus and chromosome 11 locus. Chromosome 5 locus controls the production of cytokine such as interleukin 3, interleukin 4, interleukin 5, interleukin 9, and interleukin 39 GM-CSF, which influence IgE production. Chromosome 11 locus linked to the beta chain of the high affinity IgE receptor, that is FcRI, on mast cells and basophils. These genetic factors explain why some people are more prone to allergies and why allergic reactions often run in families. Next is role of immunoglobulin E. Immunoglobulin E is called the reagenic antibody because it mediates allergic responses. It was first described by Rosnitz and Kustner in 1921 when they demonstrated that allergic sensitivity could be transferred via serum. Later, later Ishizaka identified the antibody such as IgE. IgE binds to mast cells and basophils via Fc receptors. When an allergen binds to the IgE on these cells, it triggers degranulation and the release of allergic mediators. This mechanism is central to all type of 1 hypersensitivity reactions. Next is mast cells. Mast cells are found in connective tissues near blood and lymphatic vessels, as well as in the skin, respiratory tract, and gastrointestinal mucosa. They contain membrane-bound granules filled with pharmacologically active substances like histamine, heparin, and proteases, etc. When these cells are activated by allergen cross-linking of IgE, they degranulate, releasing these mediators into surrounding tissues. This results in allergic symptoms such as swelling, redness, and smooth muscle contraction. Next is basophils. Basophils are the circulating counterpart of mast cells and make up less than 1% of leukocytes in blood. Like mast cells, they contain granules with mediators such as histamine. Upon activation, they release these substances, contributing to systemic allergic reactions, including anaphylaxis, while mast cells act locally, basophils are more involved in reactions that spread through the bloodstream. Next is Fc receptors for IgE. IgE antibodies bind to cells through Fc receptors. There are two main types. First is high affinity receptors and second is low affinity receptors. High affinity receptors found on mast cells and basophils. It binds to IgE very strongly even at low concentrations. When allergens cross-link IgE bound to this high affinity receptors, it triggers tyrosine phosphorylation and degranulation. Next is low affinity receptors found on B cells, macrophages, and eosinophils. It regulates the intensity of IgE responses and can also contribute to cell activation. Understanding these receptors is key to knowing how IgE mediates allergic reactions. Next is summary of type 1 hypersensitivity. So to summarize, type 1 hypersensitivity is IgE mediated. The main effector cells are mast cells and basophils. The allergic reaction is triggered when an allergen cross-links IgE antibodies bound to these cells, causing degranulation and release of mediators. This leads to vasodilation, smooth muscle contraction, increased vascular permeability, and the typical symptoms of allergy. Common examples include asthma, hay fever, food allergy, allergic rhinitis, and anaphylaxis. Understanding this mechanism is essential for diagnosis and treatment of allergic diseases. Next, what happens during type 1 reaction? Type 1 hypersensitivity reactions are initiated when an allergen binds to immunoglobulin E, that is IgE molecules that are already attached to the surface of mast cells and basophils. This binding activates these cells, causing them to release a variety of chemical mediators into the surrounding tissue. These mediators are responsible for the hallmark features of allergic reactions, that is inflammation, vasodilation, and smooth muscle contraction. So to simplify the process, you can imagine a sequence. First, an antigen is recognized by IgE, then mast cell or basophils are activated. This triggers degranulation, leading to the release of mediators, and finally, these mediators produce allergic symptoms such as swelling, redness, and bronchoconstriction. This overview sets the stage for understanding how allergic reactions occur at the cellular level. Next is stimuli for mast cell degranulation. While allergen binds to IgE, the primary trigger for mast cell degranulation, it is important to know that other stimuli can also activate these cells. Complement components, specifically the anaphylatoxins C3A, C4A, and C5A, can directly stimulate mast cells to release mediators. Certain drugs, including ACTH, codeine, and morphine, can have similar effects. Additionally, chemical compounds like ionophores, compound 48 by 80, and melittin from bee venom can also trigger degranulation. The key point for student is that all these triggers, whether allergen related or chemical, ultimately causes the mast cell or basophil to release the same types of mediators, leading to allergic symptoms. This shows that the degranulation process can be initiated by multiple pathways, not just allergens. Next is mechanism of IgE mediated degranulation. The core mechanism of IgE mediated degranulation begins when an allergen binds to IgE molecule attached to this Fc receptors on mast cell or basophils. However, binding of a single IgE molecule is not enough. Degranulation requires cross-linking of two or more complexes. This cross-linking sends a signal inside the cell that activates protein tyrosine kinase and increases intracellular calcium levels. These signaling events trigger granules within the mast cell to fuse with each other and with the plasma membrane, releasing preformed mediators such as histamine. Simultaneously, new mediators like prostaglandins and leukotrienes are synthesized from arachidonic acid. The outcome is a rapid allergic response characterized by bronchoconstriction, edema, and mucus secretion. So it will help visualize the sequence from allergen recognition to the physiological effect. This is PG is prostaglandins and LTs is leukotrienes. Next is cross-linking of receptors. Cross-linking is a critical step for initiating mast cell degranulation. If an allergen binds to only one IgE molecule, no reaction occurs. Degranulation only happens when two or more IgE FcRI complexes are cross-linked by a multivalent allergen. This cross-linking brings the receptor together, initiating the intracellular signaling that leads to the release of mediator. So this cross-linking happened because this signal causes granule fusion and mediator release. Next is signal transduction events. Once cross-linking occurs, a series of intracellular events takes place. First, protein tyrosine kinase are activated, followed by a rapid increase in intracellular calcium concentration. These changes signal the granules within the mast cell to fuse with each other and with plasma membrane. At this point, two types of mediators are released: preformed mediators, which are already stored in granules, are released immediately. In parallel, newly synthesized mediators derived from arachidonic acid are produced. These mediators act on smooth muscle, blood vessels, and mucosal surfaces, causing contraction, increased vascular permeability, and mucus secretion. This is the cellular explanation for the clinical symptoms of allergic reactions. Next is mediator of type 1 reaction. Mediator released during type 1 hypersensitivity can be categorized as primary and secondary. Primary mediators are performed and stored in the granules of mast cells and basophil. This include histamine, heparin, and proteases, and chemotactic factors that attract neutrophils and eosinophils. Secondary mediators are synthesized following degranulation or the breakdown of phospholipid. They include leukotrienes, prostaglandins, platelet activating factor, bradykinin, and cytokines such as IL-4, IL-5, and TNF alpha. Together, these mediators orchestrate the vascular smooth muscle and inflammatory responses characteristic of allergic reaction. This classification helps students understand that some mediators act immediately while others contribute to sustained inflammation. Next is primary mediator histamine. Histamine is a key mediator stored in mast cell granules and synthesized from histidine. It acts on three types of receptors, that is H1, H2, and H3. Binding to H1 receptor causes smooth muscle contraction, increased vascular permeability, and mucus secretion, responsible for the classic symptoms of allergy such as sneezing, itching, and swelling. H2 receptors primarily increase gastric acid secretion and mucus production, and also provide negative feedback to inhibit further degranulation. H3 receptors helps regulate the synthesis of release and release of histamine. Antihistamines work by blocking H1 receptors to relieve allergic symptoms. So explaining histamine receptor types helps student link molecular mechanism to clinical manifestations. Next is secondary mediators, arachidonic acid metabolites. Secondary mediators are generated after mast cell degranulation through metabolism of arachidonic acid, which is liberated from membrane phospholipids by phospholipase A2. There are two main pathways, the cyclooxygenase pathway and lipooxygenase pathway. The cyclooxygenase pathway produces prostaglandins like PGD2, while lipooxygenase pathway produces leukotrienes such as LTB4, LTC4, LTD4, and LTE4. These mediators have long-lasting and more potent effects than histamines. Leukotrienes are particularly powerful bronchoconstrictors, up to 1,000 times more potent than histamine, and increase vascular permeability and mucus secretion. Prostaglandins also contribute to bronchoconstriction and vasodilation. So these leukotrienes are 1,000 times more potent than histamines. Next is cytokines released in type 1 reaction. Mast cells and eosinophils also release cytokines which play a crucial role in amplifying and sustaining the allergic response. IL-4 stimulates B cells to produce more IgE. IL-5 recruits and activates eosinophils, and IL-6 promotes local inflammation. TNF-alpha is a potent mediator that can contribute to systemic effects like shock in severe reactions. Cytokines after the cytokines alter the tissue microenvironment, recreate additional immune cells, and enhance inflammation. These demonstrate that type 1 hypersensitivity is not only about immediate mediator release but also involves a complex network of immune signals that sustain the reaction. Next is biological effects of mediator. The mediators released during degranulation affects both local tissue and the body systematically. Locally, they cause vasodilation leading to redness and swelling. Smooth muscle contraction result in bronchospasm, and mucus secretion causes nasal congestion and airway obstruction. In severe reactions, mediators can enter systemic circulation, leading to anaphylactic shock characterized by hypotension, airway obstruction, and potentially life-threatening cardiovascular collapse. So these all affect biological effect of mediators, that is local effects and systemic effects. Next is summary of IgE mediated degranulation. So in summary, type 1 hypersensitivity is triggered by allergen cross-linking of IgE antibodies on mast cell and basophils. This initiates a series of intracellular signaling events that culminate in granule fusion and mediator tissue. Mediator release. Primary mediators such as histamine, protease, and heparin acts immediately, whereas secondary mediators, including leukotrienes, prostaglandins, and cytokines, contribute to sustained inflammation. The net result is allergic inflammation and tissue injury, manifesting clinically as swelling, redness, bronchoconstriction, mucus secretion, and in severe cases, anaphylactic shock. Emphasizing this pathway helps students understand how molecular events translate into clinical allergic symptoms. Next is this introduction to type 1 hypersensitivity. So type 1 hypersensitivity is an immediate allergic reaction that occurs when the immune system responds inappropriately or to harmless antigens called allergens. These reactions are mediated by IgE antibodies, which are produced specifically against the allergens. The IgE binds to mast cell and basophils, causing them to release chemical mediators like histamine, leukotrienes, and prostaglandins. These mediators cause the typical symptoms of allergy, such as swelling, redness, and smooth muscle contraction. Depending on the location, this reaction can be localized, known as atopy, or systemic, referred to as anaphylaxis. So, this will explore the factors influencing this reaction, its consequences, and examples of localized and systemic manifestations. So, factors influencing this type 1 reaction: antigen, dosage, and mode of presentation. So, several factors determine the intensity and type of type 1 hypersensitivity. So first, the dose of this antigen and the mode of its presentation affects the immune response. Low repeated dose of an allergen usually induce a persistent IgE response. On the other hand, higher dose or the use of certain adjuvants may shift the response toward IgG production. So for example, in experimental models, KLH with alum favors IgE production, whereas KLH with complete freons adjuvant favors IgG. So this shows that both the amount and presentation of the antigen influence whether an individual develops an allergic response. Next is genetic factors. Genetic factors. So genetics also play a significant role in type 1 hypersensitivity. Individuals with a family history of allergies are more likely to develop allergic reactions themselves. For instance, if both parents are allergic, there is 50% chance that their children will also be allergic. If only one parent is allergic, this drops to about 30% genes on chromosomes. 5 and 11 are particularly important in regulating IgE production and receptor expression, which explain why some families are more prone to atopy. Next is role of Th1 and Th2 cell. The balance between Th1 and Th2 helper T cells is crucial in determining the type of immune response. The Th2 cells stimulate IgE production and enhance the allergic response. In contrast, whereas Th1 cells produce interferon gamma, which suppresses IgE and promotes IgG production instead. Therefore, a stronger Th2 response favors allergy, while a Th one dominant response can reduce allergic reactions. Understanding these balance help explain why some individual develops allergies while others do not. So consequences of type 1 reaction. Type 1 hypersensitivity was first described by Charles Richard in 1902, who coined the term anaphylaxis to describe severe, sometimes fatal allergic reactions. There are two main forms, that is systemic anaphylaxis and localized anaphylaxis, that is atopy. So, systemic anaphylaxis, which can be life-threatening and affects the whole body, and localized anaphylaxis, also called atopy, which is limited to specific tissues. These reactions demonstrate how an otherwise protective immune response can cause significant harm if misdirected. Next is systemic anaphylaxis. Systemic anaphylaxis is a severe shock-like reaction that develops within minutes after exposure to an allergen in a sensitized individuals. Common triggers include medications like penicillin, insulin, or and insect stings. The reaction involves widespread mast cell degranulation, causing bronchial constriction, low blood pressure, and in severe cases, asphyxia. Immediate treatment with epinephrine is critical to reverse this life-threatening effects. While rare in humans, it highlights the extreme consequences of an uncontrolled type 1 reaction. Next is localized anaphylaxis atopy. Localized anaphylaxis or atopy occurs when allergic reactions are confined to specific tissues such as the skin, lungs, eyes, nose, or gut. Common allergens include pollen, dust, animal dander, and certain foods. Example include allergic rhinitis, that is hay fever, asthma, urticaria, that is hives, and food allergens. In these reactions, mast cell release mediators at the site of allergen entry, causing symptoms limited to the affected tissues rather than a full body reaction. Next is allergic rhinitis, that is hay fever. Allergic rhinitis, commonly known as hay fever, is triggered by airborne allergens such as pollen. Mast cells in the nasal mucosa and conjunctiva are sensitized to these allergens. Upon re-exposure, they release histamine and other mediators, leading to vasodilation, increased capillary permeability, and fluid accumulation. This results in typical symptoms like sneezing, nasal congestion, and watery eye. Treatments include antihistamines and desensitization therapies to reduce the allergic response. Next is asthma. Asthma is another common manifestation of localized type 1 hypersensitivity. It can be triggered by allergens, dust, infections, or even exercise. And asthma, mast cell mediators like histamine, leukotrienes, and prostaglandins cause bronchoconstriction, mucus secretion, and airway inflammation. Asthma has two phases: an early phase occurring within minutes, mediated by histamine and leukotrienes, and a late phase occurring hours later, mediated by cytokines like interleukin 4, interleukin 5, TNF alpha, and recruitment of eosinophils and basophil. The late phase contributes to sustained airway obstruction and chronic inflammation. Next is role of eosinophils in asthma. Eosinophils play a key role in the late phase response of asthma. They are recreated to the site of allergen exposure by cytokines and mediators. Activated eosinophils release inflammatory substances such as leukotrienes, major basic protein, eosinophil, cationic protein, and eosinophil chemotactic factor. While this mediators helps in defending against parasites like schistosoma and trichinella, excessive release contributes to tissue damage, mucus plugging, and worsening of asthma symptoms. Next is detection of type 1 hypersensitivity. Type 1 hypersensitivity can be diagnosed using simple test. Skin testing involves injecting small amount of allergen intradermally in allergic individuals. Mast cells release histamine, producing a wheal and flare reaction within 30 minutes. It is inexpensive and allowing testing for multiple allergens at once. Laboratory methods include RIST, which measures total serum IgE, and RAST, which detects allergen-specific IgE. These tests help identify the positive allergen and guide treatment. Next is hyposensitization, allergen immunotherapy. Hyposensitization involves repeated injections of gradually increasing doses of allergen. This therapy induces a shift from IgE to IgG antibodies, also known as blocking antibodies. It also shifts the immune response from a Th2 dominated profile toward Th1, suppressing IgE production. The overall effect is a reduction in allergic symptoms and severity, making it an effective long-term strategy for allergy management. Next is food allergens. Food allergies. Certain food can trigger localized anaphylaxis in the gastrointestinal tract. Mast cell degranulation in the gut causes smooth muscle contraction, leading to vomiting, diarrhea, and cramps. Some allergens are absorbed and may trigger systemic symptoms such as asthma or urticaria, depending on the site where sensitized mast cells are located. This allows that the site of mast cell activation determines the type of allergic manifestation. Next is atopic dermatitis, that is allergic eczema. Atopic dermatitis is common in young children and often associated with a family history of atopy and elevated IgE levels. The reaction is dominated by Th2 cells and eosinophils rather than Th1 cells. Skin lesions are erythematous, itchy, and may contain pus. Unlike delayed hypersensitivity reactions, atopic dermatitis is immediate and IgE mediated, highlighting the role of the Th2 immune response in allergic skin diseases. Next is late phase reaction. The late phase reaction occurs 4 to 6 hours after the initial allergic response and can last up to 1 to 2 days. It is characterized by infiltration of neutrophils, eosinophils, macrophages, lymphocytes, and basophils. Mast cell derived cytokines like TNF alpha and interleukin 1 mediate this reaction. Eosinophils play a major role releasing inflammatory mediators that sustain tissue inflammation and contribute to prolonged symptoms even after the initial allergen exposure has ended. Next is type 2 hypersensitivity. Type 2 hypersensitivity reaction are also called antibody mediated cytotoxic reaction. In this reaction, the immune system produces antibodies, usually IgG or IgM, that specifically target antigens present on the surface of cells or in tissues. Once these antibodies bind to the antigens, they can trigger a cascade of events that ultimately lead to the destruction of these cells. There are three main mechanisms by which this occurs. First is complement mediated lysis, where the classical complement pathway is activated to destroy the target cell. Second is opsonization, where Antibodies act as a flag marking the cells for phagocytosis by macrophage and neutrophils. And third, antibody dependent cell mediated cytotoxicity, that is ADCC, where natural killer cells or other cytotoxic cells recognize the antibody coated targets and kill them. These reactions can lead to tissue injury or inflammation depending on the site and types of antigen. Next is mechanism of type 2 reaction. In type 2 hypersensitivity, the reaction begins when antibodies bind to antigen present on the surface of cell. This binding triggers three important immune mechanisms. First, the complement activation. The complement system can be activated, leading to the formation of a membrane attack complex, which creates pores in the cells, which creates pores in the cell membrane and result in lysis. So cell lysis happen. Second is antibodies act as a opsonins, marking the cells for ingestion and destruction by macrophages and neutrophils. Third, ADCC or antibody dependent cell mediated cytotoxicity occurs when NK cells and other leukocytes bind to the FC region of antibodies and release cytotoxic molecules to kill the target cells. Together, these mechanisms results in direct cell injury and localized inflammation. Next is complement mediated lysis. One of the most important mechanisms in type 2 hypersensitivity is complement mediated lysis. Here, the binding of IgG or IgM antibodies to the target cell activates the classical complement pathway. This leads to the formation of C5b to C9 membrane attack complex, which inserts into the cell membrane, forming pores. These pores disrupt the osmotic balance of the cell, leading to swelling and cell lysis. Complement-mediated lysis is commonly observed in clinical situations such as mismatched blood transfusion and drug-induced hemolytic anemia, where the target is usually red blood cells. Next is opsonization and phagocytosis. Another mechanism is opsonization, in which antibodies coating the target cells act like a marker, signaling immune cells to engulf and destroy them. Phagocytic cells such as macrophages and neutrophils have Fc receptors that recognize the constant region of the bound antibodies. This recognition triggers phagocytosis, where the target cell is internalized and destroyed. Opsonization ensures that antibody-bound cells are efficiently removed from the circulation, preventing further damage. Next is antibody-dependent cell-mediated cytotoxicity, ADCC. ADCC is a mechanism where cytotoxic cells such as natural killer NK cells, macrophages, eosinophil bind to the Fc region of antibodies already attached to a target cell. Unlike phagocytosis, the target cell is not ingested. Instead, the cytotoxic cells release enzymes and toxic molecules that kill the target cell externally. This mechanism is especially important in controlling viral infections and tumor cells, where the immune system needs to eliminate infected or abnormal cells without engulfing them. Next is examples of type 2 hypersensitivity. Type 2 hypersensitivity reactions are clinically significant and can target either self cells, that is autoimmunity, or foreign cells. Some important examples include mismatched blood transfusion reaction, where antibodies attack donor red blood cells, hemolytic disease of the newborn, due to maternal antibodies against fetal red cells, drug-induced hemolytic anemia, or purpura, where drugs induce antibody formation against blood cells. Good pasture syndrome, an autoimmune disease against kidney and lung basement membrane. Myasthenia gravis, where antibodies target acetylcholine receptors, and Graves' disease, involving antibodies that stimulate thyroid hormone production. Next is mismatched blood transfusion reaction. In a mismatched transfusion, the recipient received red blood cells with antigens that are not present in their own blood. For example, if someone with blood group A receives blood from group B, their pre-existing IgM antibodies recognize the donor red cells as foreign. These antibodies activates complement, leading to agglutination and lysis of the donor cells. The patient may experience symptoms such as fever, chills, jaundice, hemoglobinuria, and even shock in severe cases. So these highlights the importance of proper blood grouping and cross-matching before transfusion. Next is hemolytic disease of the newborn, that is erythroblastosis fetalis. Hemolytic disease of the newborn occurs when an Rh negative mother carries an Rh positive fetus. During the first pregnancy, fetal red blood cells can enter the mother's circulation, causing her immune system to produce anti-Rh antibodies. In subsequent pregnancies, these antibodies can cross the placenta and bind to fetal red blood cells, causing destruction of the fetal cells. The baby may develop anemia, jaundice, an enlarged liver or spleen, and in severe cases, death. Administration of anti-Rh immunoglobulin, that is ROGAM, to the mother after delivery prevents antibody formation and protects future pregnancies. Next is drug-induced hemolytic anemia and purpura. Certain drugs such as penicillin, cephalosporin, and streptomycin can attach to red blood cell membranes, forming a drug-protein complex. In some individuals, this complex is recognized as foreign, triggering antibody formation. These antibodies then bind to red blood cells and activate the complement system, causing hemolysis and anemia. A similar mechanism occurs in syndromic purpura, where antibodies target platelets instead of red blood cells. This example demonstrates how drugs can inadvertently trigger type 2 hypersensitivity reactions. Next is Goodpasture syndrome. Goodpasture syndrome is an autoimmune type 2 hypersensitivity reaction. Here, autoantibodies target basement membrane antigens in the kidney and lungs. Binding of these antibodies activates the complement system, resulting in inflammation and tissue damage. Clinically, this manifests as glomerulonephritis in the kidneys and pulmonary hemorrhage in the lungs. The reaction demonstrates how type 2 sensitivity can cause severe autoimmune disease when the immune system targets self-antigens. Next is myasthenia gravis. In myasthenia gravis, antibodies are produced against acetylcholine ACH receptors at the neuromuscular junction. These antibodies prevent acetylcholine from binding normally, blocking nerve signals to muscle. Additionally, the complement system may degrade the receptors. As a result, patient experience muscle weakness, dropping eyelids, difficulty swallowing, and progressive paralysis. These conditions highlight the role of antibody-mediated receptor disruption in type 2 hypersensitivity. Next is Graves' disease. In Graves' disease, autoantibodies target the thyroid stimulating hormone, that is TSH receptor. These antibodies, known as LATS, long acting thyroid stimulator, mimic TSH and continuously stimulate the thyroid gland, leading to excessive thyroid hormone production, that is hyperthyroidism. Since the antibodies are IgG, they can cross the placenta and potentially cause neonatal Graves' disease. This example demonstrates how type 2 hypersensitivity can result in both stimulation and damage to target tissue. So summary for type 2 hypersensitivity. Type 2 hypersensitivity is an antibody mediated cytotoxic reaction primarily involving IgG or IgM antibodies. These antibodies target cell surface or tissue antigens and cause damage through complement mediated lysis, opsonization with phagocytosis and ADCC. This reaction can involve self-antigens leading to autoimmune diseases or foreign antigens leading to transfusion reaction and hemolytic diseases. Key clinical examples include blood transfusion reaction, hemolytic diseases of the pneumonia, drug-induced hemolytic anemia, Goodpasture syndrome, myasthenia gravis, and Graves' disease. Understanding these mechanisms is crucial for both diagnosis and treatment purpose. Next is type 3 hypersensitivity. Type 3 hypersensitivity reactions are caused by the formation of immune complexes, which are combinations of antigens and antibodies. These complexes can deposit in small blood vessels and tissues throughout the body. Once deposited, they trigger activation of the complement system, leading to inflammation and damage to the surrounding tissue. This type of hypersensitivity often affects areas such as the joints, kidneys, heart, and skin, resulting in clinical conditions like arthritis, nephritis, carditis, and vasculitis. Essentially, the immune system's response, which is meant to protect, ends up causing tissue injury. Next is mechanism overview. To understand the mechanism of type 3 reaction, start with the formation of immune complexes when antigens and antibodies bind together. These complexes may circulate and eventually deposit in the walls of blood vessels or other tissues. The presence activates the complement system, leading to the release of C3A, C4A, and C5A, which are anaphylatoxins that trigger inflammation. Neutrophils are then recruited to the site, attempting to clear the immune complexes. However, this often results in tissue injury due to the release of immune complexes. So, due to the release of enzymes, free radicals, and cytokines, and this cytokines like TNF alpha and interleukin 1. So the immune system in trying to remove the complex damages host tissue. Next is pathogenesis of tissue injury. The deposited immune complexes lodge in the basement membrane of small blood vessels where they cannot be easily removed. Complement activation increases vascular permeability, which allows more immune cells and proteins to reach the site. Neutrophils try to phagocyze the complexes, but because the complexes are fixed to the tissue, the neutrophils cannot engulf them fully. This leads to frustrated phagocytosis, where neutrophils release their lytic enzymes, causing local inflammation, edema, necrosis, and even formation of small blood clots or microthrombi. This explains why tissue around blood vessels often show signs of severe inflammation in type 3 reactions. Next is mediators involved. The tissue damage can seen in type 3 reaction is mediated by multiple molecules. First, complement fragments, that is C3A, C4A, and C5A, act as anaphylatoxins and induce mast cell degranulation. Mast cells then release histamine and 5-hydroxytryptamine, that is 5-HT, which increase vascular permeability and cause edema. Macrophages release cytokines such as TNF alpha and interleukin 1, which amplify the inflammatory response. Neutrophils recruited to the site release enzymes and free radicals that directly destroy tissue. Additionally, platelet aggregation may occur, forming microthrombi and further compromising tissue integrity. Altogether, these mediators coordinate the harmful inflammatory response. Next is generalized type 3 reaction, that is serum sickness. A classic example of a generalized type 3 reaction is serum sickness, which historically occurred after large doses of foreign proteins, such as horse antitoxin, were administered. When these proteins enter the bloodstream in excess, small immune complexes form that are not efficiently cleared. They circulate and deposit in tissues, triggering inflammation. Clinically, serum sickness manifests as fever, urticaria, rash, arthritis, nephritis, and even carditis or vasculitis. The onset usually occurs 7 to 10 days after exposure. It's important to note that the reaction is not due to the therapeutic effect of the serum, but the immune system's response to foreign proteins. Next is pathogenesis of serum sickness. The mechanism starts with entry of foreign proteins into the bloodstream, which are recognized as antigens. The body produces antibodies that form immune complexes. These complexes then deposit in blood vessels and tissues, activating the complement system and initiating inflammation. Neutrophils, mast cells, and macrophages are recruited, releasing enzymes and cytokines which contribute to tissue damage. The clinical symptoms subside once the immune complexes are cleared by the body. Serum sickness demonstrates how even therapeutic agents can trigger harmful immune responses. Next is disease involving type 3 reactions. Type 3 reactions are involved in a variety of diseases. Autoimmune diseases such as SLE and rheumatoid arthritis arise when the immune system forms complexes against self-antigens. Certain drug reactions like penicillin or sulfonamides can also cause immune complex formation. Additionally, infections may trigger type 3 reactions, including post-streptococcal glomerulonephritis, erythema nodosum, leprosum in leprosy, malaria-related nephrotic syndrome, viral hepatitis, meningitis, trypanosomiasis, and subacute sclerosing panencephalitis, that is SSPE. In each case, immune complex deposition drives the inflammatory tissue damages. Next is localized type 3 reaction, that is Arthur's reaction. The Arthur's reaction is localized type 3 hypersensitivity that occurs in the skin of individuals with pre-existing antibodies to a specific antigen. When the antigen is injected, immune complexes form locally, triggering complement activation and mast cell degranulation. This leads to hemorrhage and edematous lesions, which typically develops within 2 to 8 hours and lasts for 12 to 24 hours. Tissue necrosis may occur due to microvascular thrombosis. The reaction is named after Nicholas Maurice Arthurs, who first described in 1903. Next is mechanism of Arthur's reaction. Mechanistically, the injected antigen binds to circulating antibodies at the injection site, forming immune complexes. The complement system is activated, generating C3A and C5A, which trigger mast cell to degranulate, releasing histamine and other mediators. This caused increased vascular permeability, edema, and hemorrhage. Neutrophils accumulate at the site, releasing enzymes that lead to tissue necrosis and thrombosis. This localized inflammatory reaction highlights how immune complexes can cause severe tissue injury even in confined area. Next is Intrapulmonary arthritis type reaction. Immune complex reaction can also occur in the lungs called hypersensitivity, pneumonitis, or alveolitis. In here, inhaled antigens form immune complexes in alveolar walls, triggering inflammation. Common examples include farmer's lungs disease, spores of thermophilic actinomycetes in moldy hay, pigeon fancier's disease, protein antigens from dried pigeon feces. Next is cheese washer's disease, that is Penicillium calcispores, and last is furry's lungs disease, proteins from fox fur. The inflammatory reaction can lead to alveolitis, pneumonitis, and chronic lung injury if exposure is repeated. Next is detection of immune complexes. Detection of immune complexes is important for diagnosis. Immunofluorescence can visualize complexes deposited in tissues. Precipitation with polyethylene glycol, that is PEG, measures the amount of IgG involved in circulating complexes. C1q binding assays detect circulating immune complexes either using radio-labeled C1q or solid phase C1q. This test helps determine the presence and quantity of immune complexes, assisting in the diagnosis of type 3 hypersensitivity mediated diseases. Next is summary of type 3 hypersensitivity. Type 3 hypersensitivity involves tissue injury caused by immune complexes. Complement activation and neutrophil infiltration are central to the pathogenesis. Damages occur in blood vessels, joints, kidneys, lungs, and skin. Clinical examples include serum sickness, arthritis reaction, SLE, post-streptococcal glomerulonephritis, and farmer's lung. Diagnosis relies on immunofluorescence and C1q binding assays. Understanding this mechanism highlights how the immune system, while protective, can inadvertently cause significant tissue damage when complexes are not cleared effectively. Next is introduction of type 4 hypersensitivity. Type 4 hypersensitivity, also called delayed type hypersensitivity, that is DTH, is a form of immune response that is entirely cell mediated, meaning no antibodies are involved. Unlike type 1, type 2, and or type 3 hypersensitivity, here T lymphocytes, especially Th1 cells, are the main drivers of the reaction. In some cases, cytotoxic CD8 plus T cells may also participate. The reaction is termed delayed because it generally develops 12 to 72 hours after exposure to the antigen. Common examples include contact dermatitis, tuberculin skin test, and granulomatous inflammation seen in infections like tuberculosis. So this will explore how these reactions occur and their clinical significance. Next is key features of type 4 hypersensitivity. The hallmark of type 4 hypersensitivity is its delayed onset. Symptoms usually appear after 12 to 74 hours after exposure to the antigen. The effector cells are primarily activated T cells and macrophages, unlike other hypersensitivities where antibodies play a major role. The key cytokines involved include IL-2, interleukin-2, IFN, interferon gamma, TNF, beta, and MIF, which help recruit and activate macrophages. The immune infiltrate is predominantly composed of macrophages and T lymphocytes, and the overall effect is localized inflammation and tissue destruction at the site of antigen exposure. These features distinguish type 4 from antibody-mediated hypersensitivity reaction. Next is mechanism of delayed hypersensitivity. The mechanism occurs in two phases, that is sensitization and effector. Sensitization phase, when an antigen first enters the body, it is processed by antigen presenting cells, that is APCs, such as macrophages or Langerhans cells. These APCs present the antigen on MHC2 molecules to naive Th1 cells, which become activated and form memory cells. Effector phase upon re-exposure to the same antigen, the memory Th1 cells quickly release cytokines like interleukin 2, IF, and gamma, TNF beta, and MIF. These cytokines recruit macrophages to the site and activate them, leading to release of lytic enzymes and inflammatory mediators. So the final result is inflammation and tissue damage, which is visible after 1 to 3 days antigen exposure, hence the delayed characteristic it is named. Next is cytokines involved and their effects. Cytokines are essential mediators in type 4 hypersensitivity. Interleukin 2 secreted by Th1 cells primarily stimulates T cell proliferation, ensuring an amplified immune response. Next is interferon gamma activates macrophages, enhancing their ability to phagocytes and killing pathogens. TNF beta further increases macrophage cytotoxic activity and contributes to tissue damages. MIF, that is macrophage migration inhibitory factor, prevents macrophage from leaving the site, enhancing their accumulation and sustaining inflammation. Understanding these cytokines helps why type 4 reactions are cell-mediated, localized, and potent, with significant tissue injury if prolonged. Next is histological features. Microscopically, type 4 hypersensitivity lesions show dense infiltrates of macrophages and T lymphocytes. Unlike type 3 reactions, neutrophils are not prominent. The tissue damage seen in this reaction is due to activated macrophage releasing lytic enzymes and other mediators. So over time, this can cause chronic inflammation, and the visible lesions are the result of ongoing cellular infiltration and tissue destruction. Next is examples of delayed hypersensitivity disorders. Type 4 hypersensitivity manifests in several clinical conditions. The most common example include contact dermatitis, skin reactions to chemicals or metals. Second is tuberculin hypersensitivity, the basis of the PPD test. Next is granulomatous hypersensitivity, chronic reactions to persistent intracellular pathogens like Mycobacterium tuberculosis. And last is T cell mediated cytotoxicity seen in drug reactions or viral infections where CD8 plus T cells destroy target cells. So we'll go through each of these examples in detail to understand the mechanism and clinical signs. So contact dermatitis occurs when the skin comes into contact with certain chemicals or metals or plant substances. Common examples include nickel, chromium dyes, penicillin, turpentine, cosmetics, and poison ivy or oak. These substances are often not directly antigenic. They act as haptens, which binds to skin proteins to form antigenic complexes. The reaction usually develops within 48 hours of re-exposure in a previously sensitized individual. Next is mechanism of contact dermatitis. So the mechanism involves several steps. First is hapten penetration. Here, small molecules penetrate the skin and bind to proteins, forming new antigens. Second is antigen presentation. Langerhans cells process and present these antigens via MHC2 molecules to Th1 cells and lymph nodes. Third, cytokine release. On re-exposure, Th1 cells secrete cytokines that recruit macrophages and other inflammatory cells to the skin. And last is clinical effect. So this inflammatory response lead to redness, itching, and vesicle formation, which we recognize as eczema. So this example clearly shows how cell-mediated immunity alone can drive a hypersensitivity reaction. Next is clinical features of contact dermatitis. So, clinically, patients present with erythema, that is redness, itching and swelling, and vesicle or blisters. The reaction appears 24 to 48 hours after re-exposure and generally resolve once the offending agent is removed. This highlights the delayed nature and localized inflammation of type 4 hypersensitivity. Next is tuberculin hypersensitivity. The tuberculin skin test assesses cell-mediated immunity against Mycobacterium tuberculosis. A small amount of tuberculin, that is PPD, is injected intradermally into a previously sensitized individual. A reaction develops after 48 to 74 hours within a raised form red area called induration. This test is a classic example of type 4 hypersensitivity in a clinical diagnostic setting. Next is mechanism of tuberculin reaction. After the intradermal injection, APCs process the antigen and present it to memory Th1 cells. Th1 cells release cytokines recruiting macrophages, lymphocytes, and monocytes to the injection sites. These recreated cells cause localized inflammation leading to the characteristics induration. So other antigens such as Mycobacterium leprae or Leishmania tropica can trigger similar reaction in sensitized individuals. Next is clinical significance of tuberculin test. A positive test indicate the presence of memory T cells either from prior infection or vaccination, that is BCG. A negative test could mean no prior exposure or immunosuppression. This test is important in diagnosing latent tuberculosis and assessing cell-mediated immune competence. Next is granulomatous hypersensitivity. So granulomatous hypersensitivity occurs when macrophages engulf pathogens but fail to kill them, resulting in chronic inflammation. This persistent stimulus continuously activates Th1 cells, causing the accumulation of macrophages, lymphocytes, and fibroblasts. Common examples include tuberculosis, leprosy, listeriosis, and certain fungal or helminth infection. This is the most delayed type 4 reaction, often developing over weeks. Next is mechanism of granulomatous hypersensitivity. Persistent antigen exposure causes continuous activation of Th1 cells which secrete cytokines that recruit macrophages, lymphocytes, and fibroblasts. These cells form a granuloma, a localized nodular lesion, for example, skin, that is leproma in leprosy, and second is lung, that is tubercle in tuberculosis. Granuloma are the body's way of containing persistent pathogens that it cannot eliminate. Next is structure of a granuloma. Microscopically, a granuloma consists of central macrophages which may fuse into giant cells. It is surrounded by epithelioid cells and lymphocytes. Fibrosis may occur in chronic cases. This function of the granuloma is to wall off and contain the persistent antigen, preventing its spread while the immune system attempts to clear the pathogen. Next is T cell mediated cytotoxicity. In some type 4 reaction, CD8 plus cytotoxic T lymphocyte, that is CTLS, are responsible for cell damage. This occurs when reactive chemicals or haptens enter cells and bind cytoplasmic proteins to form neoantigens. These neoantigens are presented via MHC1 molecule to CTLS. Activated CTLS then kill the target cells, causing tissue injury. This mechanism is crucial in drug reaction, viral infection, and transplant rejection. Next is example of T cell mediated cytotoxicity. Example include drug reactions. Drug reaction when chemicals bind intracellular proteins and elicit CTL responses. Viral infection, where infected cells are targeted and lysed by CD8 plus T cells. Next is transplant rejection, where donor cells are recognized as foreign and eliminated by cytotoxic T cells. So this highlights that type 4 hypersensitivity is not only delayed but can also be cytotoxic depending on the effector T cell involved. Next is summary of type 4. So type 4 hypersensitivity is a delayed T cell mediated response. No antibodies are involved. Instead, Th1 cells, macrophages, and sometimes CD8 plus T cells are the main effectors. Key cytokines include IL-2, IFN gamma, TNF beta, and MIF. Examples: contact dermatitis, tuberculin reaction, granulomatous hypersensitivity, and T cell mediated cytotoxicity. So, understanding type 4 hypersensitivity is important clinically as it explains many chronic inflammatory diseases, diagnostic tests, and adverse drug reactions. It also illustrates the critical role of T cell in immune defense and pathology. Next, this schematic representation of the four types of hypersensitivity responses. So type 1 hypersensitivity is also known as anaphylactic or immediate hypersensitivity. When an allergen such as pollen or food protein enters the body, it binds to IgE antibodies that are already attached to mast cells and basophils through their FC receptors. So the cross linking of IgE molecule triggers degranulation. The mast cell release histamine, leukotrienes, and other vasoactive mediators. So these substances cause vasodilation, increased vascular permeability, and smooth muscle contraction, leading to symptoms like itching, swelling, bronchoconstriction, and even systemic anaphylaxis. So clinically, we see this in hay fever, asthma, hives, food allergies, and eczema. Next is type 2 cytotoxic antibody dependent hypersensitivity. So this slide focuses on antibody binding to cell surface antigen, that is complement activation or ADCC. In type 2 hypersensitivity, the antibodies, mainly IgG or IgM, bind to antigens that are present on the surface of the body's own cell. Once bound, these antibodies trigger complement activation or recruit cytotoxic cells that destroy the target cell. This process is called antibody-dependent cell-mediated cytotoxicity or ADCC. Example include transfusion reaction, hemolytic disease of the newborn, and autoimmune hemolytic anemia. Essentially, this type targets the body's own cells, marking them for destruction as if they were foreign. Next is type 3 immune complex mediated hypersensitivity. Type 3 hypersensitivity occurs when antigen antibody complexes form in the circulation and get deposited in various tissues, especially in the blood vessels, wall, kidneys, joints, and skin. These immune complexes activate complement, which attracts neutrophils to the site. So, as neutrophils try to phagocytose the complexes, they release enzymes and toxins molecules that damage surrounding tissue. This results in inflammatory lesions such as vasculitis, arthritis, and nephritis. Clinically, examples include Arthur's reaction, that is localized, and serum sickness, that is generalized, as well as diseases like systemic lupus, erythematosus, and rheumatoid arthritis. And last is type 4 cell mediated, that is delayed type hypersensitivity. Unlike this previous three hypersensitivities, type 4 hypersensitivity is mediated entirely by T cells, not antibodies. This is why it is called cell-mediated or delayed type hypersensitivity, as the reaction develops after 48 to 72 4 hours of exposure. When an antigen is presented to sensitize Th cells, they release cytokines such as IFN, gamma, and TNF, which all activate macrophages and promote inflammation. So in some cases, cytotoxic T cells, that is CD8 plus cells, directly kill target cell. Common example include contact dermatitis, the tuberculin skin test, and granulomatous inflammation seen in tuberculosis and leprosy. So, quick summary chart for type 1, type 2, type 3, and type 4. Type 1 IgE plus mast cell equals to immediate allergy. Type 2 IgG or IgM plus cell surface antigens gives cytotoxicity. Type 3 immune complexes complement plus neutrophil gives inflammation, and type 4 T cells plus cytokines leads to macrophage activation, that is delayed damage. Each type represent the a unique way the immune system, while trying to protect us, can end up causing tissue injury. So you can view this quick summary chart for the type 1, 2, 3, and 4 for its mechanism or mean cell antibody or time of reaction or example as well. So with this, we completed today's class. Questions for 3 mark. First, define hypersensitivity and name its 4 types. Second, what is the difference between immediate and delayed hypersensitivity? Third, name the antibody and cells involved in type 1 hypersensitivity. Fourth, list 2 examples of each type 1 and type 2 hypersensitivity. Fifth, define cytotoxic hypersensitivity and mention 1 example. Sixth, what is an immune complex? Give 1 example of a disease caused by it. 7, what is the difference between type 2 and type 3 hypersensitivity? 8, what is type 4 hypersensitivity called delayed type? Why it is called delayed type? 9, write short notes on contact dermatitis and tuberculin reaction. And 10, compare antibody mediated and cell mediated hypersensitivity. I need 2 points. Questions for 5 marks. Explain the mechanism of type 1, that is IgE mediated hypersensitivity with diagram. Second, describe the pathogenesis and effects of systemic and localized anaphylaxis. Third, explain the mechanism of 2, that is cytotoxic hypersensitivity with example. Fourth, describe the mechanism of hemolytic disease of the newborn. Fifth, discuss the mechanism of type 3, that is immune complex mediated hypersensitivity. 6, explain the Arthur's reaction and serum sickness in detail. 7, describe the mechanism of type 4, that is cell mediated delayed hypersensitivity. 8, discuss the example of type 4 hypersensitivity, that is contact dermatitis, tuberculin reaction, and granulomatous hypersensitivity. 9, compare type 1, type 2, type 3, and type 4 hypersensitivity based on mechanism, mediators, and time of onset. And last, write short notes on clinical significance and management of hypersensitivity reaction. So with this, we completed hypersensitivity topic of immunology. We covered all parts, type 1, type 2, type 3, and type 4 as well. The main important one, for example, exam purposes, hypersensitivity, antibody dependent, and delayed type, cell mediated one. So thank you. I hope all will understand about this hypersensitivity.